Hey everyone, and welcome to this high-yield, rapid explainer of gram-negative enteric bacilli. Look, we know these bugs cause absolute chaos on the wards, right? And because there's just this massive volume of pathotypes and resistance mechanisms, they are heavily tested on the boards. So we're going to cut straight through the noise. I've structured this entire review to give you exactly what you need to recognize the buzzwords, understand the underlying mechanisms, and honestly, just confidently pick the right answer on exam day.
Here's our game plan for today. We're hitting 4 major highly testable zones: intestinal invaders, tissue destructors, a full resistance roster, and finally, those critical warnings you absolutely cannot miss. All right, let's jump straight into part 1, the intestinal invaders. And we're kicking things off with the heavy hitters, the E. coli pathotypes. When that exam clock is ticking and you're under pressure, initial-based associations are an absolute lifesaver. So let's use this little mental shortcut. S is for the Shiga toxin in S-Tech. T stands for traveler's diarrhea in E-Tech. E gives you the effacing lesions seen in E-Pec. I is for invasive, which means we're dealing with dysentery in EIIC. And finally, A is for the aggregative adherence of EAAC. Now, let's actually hook those mechanisms up to exactly what you'll see in the clinical vignette. For STEC, also known as EHEC, that Shiga toxin is driving hemorrhagic colitis and HUS. With E-Tech, you've got heat-liable and heat-stable enterotoxins causing that classic watery traveler's diarrhea, which you'll mostly see in patients returning from developing countries. Then there's E-Pec. It uses what's called a Lee pathogenicity island to create these attaching and effacing lesions, which leads to non-bloody infant diarrhea. EIEC is a bit wilder. It actually invades the colonic mucosa, behaving a whole lot like Shigella, giving you this inflammatory, bloody dysentery. And rounding it out, EAEC creates a thick biofilm on the intestinal mucosa, and that leads to this frustrating, persistent diarrhea that just drags on for more than 14 days. Okay, the one bug here we really got to double down on is S-Tech, specifically that notorious O157H7 serotype that comes from bovine reservoirs. What's crazy about this one is its shockingly low infectious dose. Literally less than 100 colony-forming unit is enough to make you sick. It pumps out the Shiga toxin, which actually irreversibly inhibits protein synthesis by cleaving an adenine residue right off the 28S RNA. Clinically, that leads straight into the highly testable HUS triad: microangiopathic hemolytic anemia, thrombocytopenia, and acute renal failure. If you see this exact triad popping up right after an episode of bloody diarrhea, boom, you are looking at S-Tech. Moving out of the gut, we hit part 2. The tissue destructors. We're going to look really closely at hypervirulent Klebsiella and Proteus. First up is hypervirulent Klebsiella pneumoniae, often abbreviated as HVKP. Now, this one has what's called a hypermucoviscous phenotype, and yes, that is literally exactly as gooey and gross as it sounds. If a board question describes a positive string test, meaning colony strings stretch more than 5 millimeters when pulled up with an inoculation loop, that is a massive clue. This specific bug loves to cause community-acquired monomicrobial pyogenic liver abscesses, and surprisingly, it does this in younger, otherwise totally healthy individuals. But what makes this bug an absolute nightmare and prime test material is its metastatic spread. It doesn't just hang out in the liver, it actually seeds to distant sites, leading to devastating complications. The big one to remember is endophthalmitis, which can result in permanent vision loss. Catching this hypervirulent strain early is just absolutely crucial. Switching systems entirely, our next tissue destructor goes after the urinary tract. Let's talk about Proteus mirabilis. This bug's superpower is urease production, which it uses to hydrolyze urea straight into ammonia. Well, what does that do? It turns the urine highly alkaline. And in that alkaline environment, you get the precipitation of these massive struvite staghorn calculi. They're made of magnesium ammonium phosphate, sometimes called triple phosphate. The ultimate exam takeaway here is that you literally cannot eradicate the infection without surgically removing the stone, because the stone itself acts like a bunker harboring the bacteria. Also, pro tip, if you're reading a vignette and you spot the phrase swarming motility on an agar plate paired with staghorn calculi, ding, 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 think Proteus mirabilis immediately. And for your lab findings, just keep in mind that Proteus mirabilis is indole negative. That's exactly how you differentiate it from the much more resistant indole positive Proteus vulgaris. So how do we actually treat these? That brings us to Section 3, the resistance roster, where we're navigating the incredibly complex world of beta-lactamases. It really is an alphabet soup of resistance out there, so let's decode it. First up, we've got the ESBLs, or extended spectrum beta-lactamases. You'll typically find these in E. coli ST131. They completely destroy all penicillins and all first through third generation cephalosporins. So your most reliable rescue therapy, carbapenems. But on the flip side, we have AMP-C resistance. Now this one is strictly tied to the space organisms. That's Serratia, Providentia, Acinetobacter, or Citrobacter, and Enterobacter. AMP-C trashes everything ESBL does, but it also takes out the cephamycins. If you're dealing with a severe AMP-C infection, you're again looking at carbapenems or potentially reaching for a fourth-generation cephalosporin like cefepime.
But here's the scary question. What happens when the bugs figure out how to beat our go-to carbapenems? Well, the CDC literally calls carbapenem-resistant Enterobacterales, or CRE, an urgent threat. And these sneaky carbapenemases are divided up into three main classes, A, B, and D. There is a huge, highly tested geographic split you need to memorize here. Class A, which includes KPC, absolutely dominates the Americas, and your first-line treatment for that is ceftazidime avibactam. Meanwhile, Class B, which features the NDM metallobeta-lactamase, is mostly found over in Asia. The critical exam point? Class B is not inhibited by avibactam on its own. To treat it, you actually have to use an astrianom combination. Knowing these exact pharmacological distinctions is a guaranteed way to score points on testing. Finally, we've arrived at the climax of our rapid review, Section 4. These are your critical warnings, the absolute red flags for the boards. Listen up, because this is a massive, life-saving red flag. If your patient presents with bloody diarrhea, no fever, and you are suspecting O177H7 STEC, do not use antibiotics. Why? Because giving antibiotics to a STEC patient stresses the bacteria, which actively increases the release of the Shiga toxin. You are literally worsening their risk of developing hemolytic uremic syndrome. It is a classic trap in board scenarios. They will dangle an antibiotic right there in the multiple choice options. Do not take the bait. Here's another massive one. Do not use third-generation cephalosporins for those space organisms we talked about. Doing so directly induces or selects for AMP-C resistance derepression. Basically, it actively triggers disastrous treatment failure. The moment you recognize a space bug, you have to mentally cross third-generation cephalosporins entirely off your list. Well, we covered a ton of ground today, right? We took the wild complexities of gram-negative enteric bacteria and distilled them down into a fast, reliable mental framework. So with these contraindications permanently locked into your memory, I'm going to leave you with this thought. The next time a patient rolls into the ER vignette with bloody diarrhea, is your instinct going to be to reach for the antibiotics, or are you going to pause and remember the Shiga toxin? Keep reviewing, trust your framework, and I'll see you in the next explainer.